is, I believe it's your job to assess where he lies on the continuum.
Good way to look at it.
It'll actually start affecting other sites of the spinal cord that's not associated with tissue damage.
But we're trying to understand, how the body works as a body, not just as a system of the body.
And we're on.
What's up, guys? So we're going to talk about pain today. So pain has a lot of different aspects to it. So the first thing that I'm going to be discussing in this podcast is the neurophysiological and anatomical mechanisms and aspects of pain. Angelo is going to get into a little bit about the more psychological, and you'll see why I put air quotes around that later on, and more central aspects of pain, so still around the science of the mechanisms. And then Chris is going to get a little bit more into the literature that supports these mechanisms, and we'll touch briefly upon treatment throughout, but we're going to have a whole separate podcast on treatment of pain depending on patient presentation. I hope you guys enjoy this podcast. Stay strong. Hello, Mr. Angelo.
Hello, how are you doing today?
Doing well.
We're live.
So we are live with Angelo Oreo, the Rutgers fan. So I wanted to start my section here with an alliteration. Sally is skipping to school. See what I did there? Sally is skipping to school.
Oh, it's
So
a tongue twister.
Yeah. Sally's selling seashells by the seashore. Ooh, I should have done that, but no. Sally is skipping to school. So la 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 la. But on her way, she looks away for a second, gets distracted, and she bangs her knee into a tree. First thing that happens. Ouch. No. Inflammation, specifically a molecule that's local to the tissue that you damage called prostaglandins, will surge in her knee. And these prostaglandins have a dual role. They're going to both initiate the healing process, and they're going to initiate the pain signal in the pain nerves that are in that area. So the prostaglandins activate those nerves, and this is called an action potential. So this allows for an electrical signal to be transmitted through the wire to your spinal cord. So you have the pain receptors in your knee, and these prostaglandins, in essence, carry that message through the wires of that nerve to your spinal cord. From there, the signal crosses over to the other side. This is why you experience pain that you experience on your right side of your body is controlled or picked up by your left side of your brain, because this track, the spinal thalamic tract, is going to cross over in your spinal cord. Not that important for us. And it's going to shoot up, eventually hitting your cerebral cortex. So pretty much that outer layer of your brain. It has all the nuclei of the cell. Again, not that important. So it's going to actually specifically go to this place that is associated with sensation in your knee. So this place is called the primary sensory cortex, and specifically the postcentral gyrus. So your postcentral gyrus is going to be in this plane, and your knee is going to be somewhere on that plane. So it's going to go to that specific area. From there, that signal goes to association cortices. All this means in layman terms is that it's going to go to your limbic system, your parietal lobe, and your occipital lobe. So it's going to say, what did I see when I had pain? What did I feel emotionally when I had pain? How can I associate my sensory systems together to really understand the situation greater? So emotional visual, other sensations are being associated with your pain. These association cortices, like I said, will lead into the emotion systems. This will lead into your hypothalamus and your brainstem. And your brainstem will go back down to your spinal cord, and it'll eventually cause a motor response. So we had a sensory signal that was sent to your brain. And now once the sensory signal is associated within the brain, your body will have a reactivity. It'll have a response. And this is a motor output. Even though it's not actual physical movement, it is a output at which it's reacting to the sensory signal. So we call this motor or afferent signal. So from the moment after Sally banged her knee up to a maximum of around 3 months, the pain is clearly due to tissue around her knee. And I think this is, without question, the pain that is associated with her knee is most likely directly caused by true tissue damage. And I wouldn't argue it any other way. For up to 3 months at most. And if you try flying your knee into a tree, the same thing will happen to you, and it will hurt. And it will be because you have damage to your knee, or there's some perceived damage. So we call this an acute pain response. So within that 3-month period, there is real tissue damage that is associated with the pain. And this pain will likely dissipate with the healing of that tissue and resolution, or proper resolution, of that inflammatory response. So if there's leftover prostaglandins, or those nerves in that knee become a little bit more sensitive, that is not a proper inflammatory response. Usually the tissue will heal properly if you do the right things, the right treatment, and all is well. Your pain should dissipate. So let's talk about some things. Sally is skipping to school. She gets up. She's in pain. She's no longer skipping, I lied. She's in pain, maybe a little tear down the cheek. Something that's going to make Sally feel better, however, as she gets to school, is this feedback mechanism that she gets from the pain. So your body's smart. Pain's an important signal, but your body will decrease or diminish the pain if it's unnecessary. So this is a feedback response. So this pain eventually reaches your emotional centers. So that's the sensory signal. That's where the sensory signal ends, for our sake. And from there, from those emotional centers, the signal, like I said, is going to start to cause a response. And this is the motor or efferent signal. I don't know if I said that right before. The motor, the activity that happens after the sensation, is the efferent, out. It goes out, exits. This signal gets relayed to the brainstem and the spinal cord, and it's going to release something, as most people know, a molecule called serotonin. And this serotonin molecule, or molecules, will get released to the spinal cord, where the pain is connecting in the spinal cord. So we had that nerve that was in her knee. It traveled to her spinal cord. It's going to connect to a different nerve on her spinal cord to shoot up to the brain. It's not one long signal. It's a wire that goes from her knee to her spinal cord, and a wire that then it connects to a wire that is in her spinal cord that pretty much goes up to her brain. There's a few more, but that's, for our purpose, that's fine. If that signal is blocked, then you're not going to feel pain, or as much pain. So that's part of serotonin's role actually here. And yeah, so that's serotonin's role. And this decrease in pain, or pain modulation, is referred to as top-down modulation. Something else that Sally's going to do while she's wimping her way to school is she's going to probably start rubbing her knee. And most people notice this. You get hurt doing something, you want to squeeze it, you want to rub it. And this actually has a pretty similar effect to serotonin for our purposes, as the touch signal that you're putting in the area. So just for argument's sake, say I hurt my hand. Ow, it hurts. If I start rubbing it, why does it feel better? It's because you're giving your body a competing signal. So That pain signal is going, it gets to my spinal cord. If I rub it, now I'm activating different receptors. So it's going to compete with that pain signal. And if it can overpower the pain signal, then you're in good shape. You're probably, the pain signal is actually going to stop competing, stop wasting that energy, because it's not going to win. So it just stops altogether if it's enough of an intensity. So top-down modulation, serotonin's role, and these competing signals like rubbing a painful spot, these are two parts of something called the gate control theory. So you're controlling the sensation that goes to your spinal cord, essentially. So it can't get up to your brain. So that's one spot. So let's say 3 months go by. Sally is, so she's go by for 3 months, 12 weeks. Sally is no longer in this acute phase. She's in this, the tissues are healed. So we looked, tissues are healed, there's no inflammation, but Sally still has pain. So the tissues are healed, still has pain. So then there must be another thing that's happening that's causing her pain. So as I just brought up this whole pain signal, Sally's pain was really in her knee. That's what was compromised, her knee. The tissues in her knee were damaged, and that was causing pain. No problem. But now there's no tissue damage. Somewhere else along the line, whether it's her spinal cord, whether it's the nerve wires themselves, whether it's in her emotional centers, in her cortex, something is causing this pain. It's a little iffy. So throughout these 3 months period, Sally is feeling legitimate pain. This is real pain. Something that she's doing, though, is every time it hurts her, she goes up the steps, it hurts. Sally has a ton of anger and resentment to her pain, fear of moving to cause pain. And this type of response might give us an insight to the mechanisms behind her pain. So it might sound a little crazy at first, but stick with me. So if she feels unhappy or depressed at the time, because of her pain or not because of her pain, but she's feeling pain, so it's correlated together, this can affect serotonin, definitely. And now if we don't have serotonin or the proper amount, this cannot modulate the pain in the spinal cord as well. So now that signal is not being blocked as it should. So that's one thing that could happen. If she has increased stress during this 3-month period, cortisol is going to increase, so that's a stress hormone, along with epinephrine. And this is generally going to cause inflammation throughout your body. So this can lead to inflammation in areas that do not have any tissue damage, but it still facilitates a pain response. So say I had a lot of inflammation on my body, I'll have an inflammatory response to a tissue that's not damaged. So it'll cause pain here, correct? So that's something. And then third, and probably most importantly and most interestingly, the anger and fear that she associates with her pain and movement can become something called a neurotag. And I'm going to try to explain this as best as I can, and I think you'll understand, everyone will understand. So all this is an output of coordinated nerve signals in the brain. So to understand this a little bit better, everybody knows Pavlov's dogs, right? And classical conditioning. So Pavlov, he was a psychologist, to my understanding. I'm probably going to botch what he did, but this is generally what he did. So, and I don't know if I said operant conditioning, it's classical conditioning that I'm talking about. I don't know the exact nuances between each, but classical conditioning. So essentially, he would pair sensory responses with food or giving a dog food, something along those lines. Anyways, he gave food to a dog and he rang a bell, for example. So he did this after many sessions. These dogs rang a bell, they got food. Rang a bell, they got food. Rang a bell, they got food. And then he would ring the bell and not give them food, but the dog's digestive system would already begin. They would already start salivating. They would already be prepared for food. Now, why is this? It's because your brain doesn't put a very simple signal out. It doesn't do that. Like if I move my arm, it's not going to just move your arm. There's so many things that are associated together, as I talked about in the pain signal, that are going to be incorporated to this motor output. So ring a bell, it's going to cause a digestive response because that's usually what the brain associated in the past. So he created a neuro tag in these dogs. And this is no different to what happened to Sally. So every time she was in pain, she would be angry or fearful of movement. And this is due to or not due to the pain, probably due to, but it doesn't really matter. She was in pain and she was angry and she was fearful of movement. So once that tissue resolved, she already had the associations built with pain, anger, and fear. So now past that, her body, her mind is going to produce pain throughout her body when she's feeling those same feelings of anger and fear. And this is not crazy talk. This is not me speculating. This is pretty
Sounds pretty voodoo to me.
It does. This is pretty agreed upon. If anybody's seen The Office before, I don't really watch The Office, but I know this one thing. Jim and Dwight. Jim does a little bit of classical conditioning to Dwight. They sit across from each other in a desk, and Jim rang a bell and gave Dwight a piece of gum or a mint or something like that every day. So they showed a bunch of times him doing that, and Dwight would just like keep going. One day Jim just rang the bell and Dwight just put his hand out, and Jim's like, "What the fuck are you doing? Why are you putting your hand out?" So he got him nice. But it's essentially the same thing. So these three things that I mentioned, these three mechanisms, this is referred to as a sensitization. So either central or peripheral. The nuances of the words don't really matter for our purposes. But these theories are definitely not entirely clear. So what we do know is the brain structures involved and how they're connected and what certain neurotags look like, but definitely nowhere near the whole picture. However, as far as helping Sally, which we'll get more to in a later podcast, basing treatment off of these mechanisms that I discussed has a really good chance, according to the literature and according to my own experience in physical therapy clinics and my own experience and the science, this will definitely or most likely help Sally if done appropriately. And of course, my treatment would differ depending on where Sally is in her stages, because if she's in that acute phase, you could put the pieces together. Where is the pain signal? If she's in the chronic phase, where is the pain signal? So it's going to be augmented at different parts along the chain, as I discussed in the beginning. But something to understand is that these phases don't turn on and off at specific times. It's not like, 3 months went by, now she's chronic. No, they're on a continuum, like anything else. They're on a spectrum, and it's probably the most acute in the beginning. So you get that real tissue damage is causing pain in the beginning, and then it slowly is probably building towards chronic pain or a sensitization over time, the longer it doesn't get resolved. That's how I'd imagine. So to summarize this, Sally's pain is definitely not stemming from her knee. It's not just stemming from her knee. So it could be augmented or reduced anywhere in the nerve pathway. And since we like Sally, me and Angelo, we would definitely be sure to be very careful to search for the point in which the pain is augmented, the point on the pain chain, for example. So is it her knee? Is it her spinal cord? Is it a nerve itself? Is it her brain? Is it her emotions? Is it her cognitions? we would be sure to understand where the pain is augmented and not just robotically decrease her symptoms. An example of this that Chris is going to get into is giving somebody opioids. We need to understand why Sally has her pain. So if someone has pain in their knee and we just rub it, great, we're treating those symptoms. But what's the true cause of the pain? And this is a very interesting topic, and it takes thoughtfulness to really help somebody the right way. So that's all I'm going to talk about. But Sally got better, so don't worry about her. She'll be all right.
Sally's good.
Sally's good.
So I'm going to talk about the mind's role a little bit in pain modulation, go a little more in depth into that. Ross touched a lot on certain aspects of pain modulation. I'm going to touch on this specific role of the mind. And I think it's a good idea to start with explaining some of the adaptations that have developed within our evolution to, in essence, optimize our human experience. Evolution of any organism entails survival of the fittest. With that, optimizing the human experience is part of survival of the fittest. So throughout evolution, our physiological adaptations have developed in ways that allow us to appropriately respond to any stimulus, really. Example of this include mechanisms of tissue remodeling after a physical injury, such as bone healing and a fracture, or even skin forming back after a cut, or the ability to filter through good and bad substances or toxins that enter our bodies. That's an adaptation that we've developed as well to survive these. All of our different mechanisms behind nutrient absorption and utilization of nutrients into energy for our cells, and the difference between all these, the metabolisms of different nutrients. That's also an adaptation that we've developed in order to survive this long. The transport of metabolites as a result of these processes, and the fight or flight response. These are all adaptations that we have developed over time via evolution and just survival of the fittest. These are just mutations that we've adapted to optimize our human experience. And I'm going to keep saying that, optimize the human experience, because I think that's going to bring you back to the idea of evolution and what the reason for all these adaptations are, really. So that last example, the fight or flight response, this is an autonomic nervous system regulated mechanism. This means that this automatic process is mediated by subcortical, or without conscious thought or control, subcortical structures and pathways. With that being said, I think it would seem illogical that there isn't a role of the mind in optimizing the human experience, as we just saw that something like the fight or flight response, which I'll touch on a little later exactly what that is, but this autonomic response is pretty much mediated by our unconscious mind. It's something that we don't think about, it just happens. So we don't have to be conscious for all of these adaptations to actually happen within our body, such as Ross was explaining, the Pavlov's dogs and salivating before now they're salivating after the bell is rung without even the food. That's an unconscious mechanism that's happening in them. So the problem is that the mind isn't studied in laboratories as much as the physical body, since it's hard to measure the power of the mind in test tubes and titrations and laboratories. So, but in Eastern cultures, it is common practice and tradition to use the power of the mind to control physical states, such as in meditation and yoga type practices. And in fact, there's new experimental studies that have demonstrated how practices like yoga and meditation not only decrease reports of pain, but also provide the activation of certain neuroprotective mechanisms for the brain matter itself. However, over here on the Western front of the globe, we've basically ignored the role and the power of the mind and have turned to other modalities to help modulate that pain, such as pharmacological interventions that I know Chris will touch on a lot more later in this podcast. Many health providers out in the West acknowledge the fact that the mind has a very important role in human health and optimizing the human experience, but that's pretty much the extent of their education to the patient, for whatever reason that might be. Even if patients do seek psychological advice, now the psych professional may not be able to explain the physiological manifestations of what's going on because of the restrictions of their studies and all those limitations. And I'm not blaming or I'm not generalizing these professions at all. That's just how the healthcare system is set up, and this mind-body connection is ignored by society and further divided by these professional splits of MDs and psychiatrists and people like us, physical therapists, who try to just treat the symptoms of the pain. There's no really clear, cut and clear area and study to the mind-body connection.
So they treat the symptoms of the pain based on whatever profession they're in.
Yeah.
So a physical therapist will treat somebody's pain with movement. A neurologist or a general physician will treat somebody's pain with opioids. A orthopedic surgeon will treat somebody's pain with steroid injections, no matter where the pain is augmented along the chain.
Right.
It's crazy. It's
Exactly.
it's unthoughtful, and it actually will compensating over time. Just with anything, if you don't have balance and you're compensating over time, you're gonna be worse off than where you were.
Yeah, and without getting too deep into it, I think that's a problem with the specialization, the super specialization of a lot of healthcare professionals as well. They're so specialized, and which is good for that specific ailment or whatever's going on, but sometimes they just miss the bigger picture because they're just so honed in on one certain aspect of the human body. But
And they're divided too. They're divided. We're always told by our teachers, advocate for your profession. It's a game of divisions. It's not everybody's working
Power.
together. Yeah, exactly. It's not about everyone working together. It's fight for your profession, fight for your specialization, not fight for your patient or a client.
yeah,
Even though they say it is, even though they say that's not what they say, not at the expense of your profession.
Mhm.
That's just straight truth. That's
Mhm.
straight truth. That's what they preach. Advocate for your profession, and that's a crime. That's how I see it.
Yeah. So I'm going to talk about the mind a little bit more, and I know Chris is going to go into more detail about this, but to understand what I'm about to talk about, I think just need to touch on a few concepts that he's going to go into as well. But so, according to Sigmund Freud's psychoanalytic theory, part of the unconscious mind is referred to as the id, which is the part of the mind that contains primitive and instinctive drives such as sexual and aggressive behaviors. Superego is the other end of that spectrum, which is the part of the mind that wants us to adapt to society and pretty much be socially acceptable. Our ego is kind of right in the middle of them two, and so it's between the id and the superego, and this represents that constant push and pull of this id and the superego. So our unconscious mind holds all of our undesirable memories and emotions, and the superego tries its best to keep them hidden from the conscious mind in order to, again, optimize the human experience and make us socially acceptable. Some experts say when we dream, we go silently insane, and this is because all of our unconscious thoughts and emotions are able to come out without the conscious mind acting to repress them, which will make sense a little later. If these undesirable emotions, such as rage and embarrassment and selfishness and the sexual drives, are able to expose themselves on an everyday basis, you're not going to be socially acceptable. You'll probably be put in jail if you have certain sexual drives that you act upon consciously, right? And this isn't going to optimize your human experience. In fact, some would say that the unconscious mind is rooted from childhood and the conditioned learning that develops as a child, as children. So it makes sense that these emotions seem to be repressed deep in our mind as we're conditioned to see things as good and bad through the events that shape our childhood. How do these emotions stay hidden deep in our brain without unconscious or without the conscious mind acting on them? Well, one part of the answer might just be this mind-body connection. It might be a piece of that bridge between the physiological and the psychological aspects of the human organism that interact to improve our human experience. So, you ever wonder what's going on when you hear stories of people who have gone to several different doctors and supposed health gurus seeking answers to why they're have this crazy chronic pain, or when patients go to physical therapy for a month, begin to feel better, then suddenly begin to feel the pain again. So they have to go back, and it's just a cycle. Well, and maybe because there might not be a real structural deformation or abnormality that can be explained as the root cause of this pain. Rather, maybe some sort of unconscious distraction to deflect your conscious mind away from these repressed emotions. And again, it seems a little crazy and voodoo-ish because, again, it's not talked about or taught in school since it can't be objectively measured in labs. So the clinical field won't use it. Right? Clinicians aren't going to use this approach because just in terms of insurance and liability, no one's going to pay for treatment that isn't backed up with evidence, which that's a whole other issue with the healthcare system. But
And we are introduced to these concepts in a light way, sprinkled in. We definitely are introduced in school to the fact that pain is multifactorial and it doesn't always have to be associated with tissue damage. But it's sprinkled in and it's forgotten. And to my understanding, medical professions, as far as like statistics, they don't learn about this at all. We learn about this a little bit because we do pain. That's what physical therapy is for. It's for treating somebody's pain and pain with movement. So we learn about it a little bit, but it's definitely not prominent to the point where it's carried over. So we've had plenty of clinical experience. Both of us had plenty of clinical experience. Like I've seen so many patients with pain. So many. I've probably seen, I don't even know. I've seen a shitload of patients. Did my CI ever consider the psychological aspect more of a, I don't really like psychological a lot because it assumes that there's no actual physiology behind it, but the
subcortical aspect.
Yeah, the subcortical aspect of somebody's pain or the more central aspect, not once. If somebody had pain and it wasn't getting better, oh, let me see why their pelvis might be off. Maybe that's why their sacrum is popping out, and that further is going to attenuate those beliefs that you need to be fixed rather than no, it's not that you need to be fixed. All you got to do is essentially maybe calm down or have better beliefs or improve your emotional awareness, your cognitive awareness. And there's specifics to that.
Yeah, and also as physical therapists, it's tough to go through a treatment approach that entails all of what we're talking about because of the restrictions of time. You're only really with patients for, I'd say, an average of a couple months, if that.
And
that,
how long are you with each patient each
oh,
day?
every time, maybe you'll see them twice, maybe if you're lucky, 3 times a week for supposedly an hour, but you really only see them for 10 minutes because you go send them off and the aides bring them through their exercises, and you're just going to give them their hands-on modalities. So, which we all know is just an acute relief of pain, a temporary relief of pain. So now what are they going to think? The most important thing are those hands-on.
Because it's when we see them.
Right.
And it's, and in essence, it's not only is it not helping long term, but I would argue that you're further pushing the beliefs that there's something structurally wrong when you put your hands on a patient. like that. And this is a big undermining in the field, is because you have to have empathy for physical therapists. You do, because some of them really, their most important thing to them is their patients, and they don't have the time, and they're getting almost threatened by these insurance companies to have these certain measurable outcomes. And it's honestly, everywhere is a pay for performance. So like, they don't have time with their patients. They have 10 minutes at the end of each session, 10-20 minutes max, to put your hands on them, because that's what they expect when they go to physical therapy. What else would you think? You're going to get massage, you're going to get a joint mobilization, you're going to get someone's hands are going to get put on you. So it's a very difficult situation for a physical therapist to say, I want to spend time looking at your thoughts and your emotions, and how can we incorporate that in our intervention too? Because that's probably the most important thing when it comes to resolving somebody's chronic pain or long-term pain.
Yeah, and time again, I've seen patients as a physical therapist. I've seen patients come in and you want to make the argument that you want to do hands-on just to make them feel better so that they are pain-free and go do their exercises without pain, then okay, seems logical, right? But now the next time they come in, you give them that massage and say, okay, pain? Okay, yeah, good. Now let's go do your exercises. Now all of a sudden, 2 minutes later, they magically get a phone call from their child's school saying they got to go pick their kid up from school. That's just a very convenient phone call for them because they just got their feel-good massage and they don't want to go exercise. And that happens all the time. It's just a cycle, and it's not sustainable at all, like Ross was saying.
And you can't blame you can't blame the therapist because they have 12 weeks. Honestly, if I was a PT, I would consider way more to do manual work. Why? Because you're not going to make sustainable differences anyway. You're dealing with 1,000 patients a year. You have with a single patient, you see them for 20 to 40 minutes a week, just you as a therapist. So what do you have to get them to buy in at least for those 12 weeks, and then those changes will go away. 8 to 12 weeks, whatever it is, then those changes will go away right after regardless. So you might as well get them somewhat good in that time frame. So I would argue that maybe I would do manual therapy as a PT, because there's not a
If you
lot
want
of
to make money,
options. No, well, there's not a lot of options for PT because you only have 8 to 12 weeks. So it's like you have to get them to buy in that small amount of time, and you're ready behind the 8 ball because they're coming to you with the physical therapy expectations of being hands-on. So are you going to spend time explaining to them why you shouldn't go hands-on? That's going to waste time, and that's going to take time to get rid of those beliefs. Whereas if you are somebody that only has 200 patients a year, and you're building long-term relationships with people instead of treating it like a factory system, now you can start instilling those beliefs, and you have more time with patients. So now you can set up sustainable practices instead of saying, you know what, let's just get an acute change every day. Oh, your back hurts, let's just put some heat on it. It's very interesting. At the very least, it's a really interesting social and societal concept, because it's just very, very, very interesting. I find it fascinating.
and the sad thing, sad but true, is that we were actually told in school by one of our professors that it is a good business model to do these types of practices, because what's going to happen, they're just going to have to keep coming back. You're just going to make them dependent on your massages or whatever you're giving to them. So, and it's sad because on the other hand, they'll preach, oh, it's all about optimizing the patient's experience, but
It's a scam.
which one is it? It's a scam. It's a scam.
And further on that business model, really quick, what they were insinuating, whoever this professor was, they were insinuating is that you have a patient for 8 to 12 weeks, you get them better, you just make them feel better every single time they come in. The patient thinks that's success, when they don't realize they can have success long-term success, because you've conditioned them to believe that there is no long-term success. You just have to do something to feel better every single time you come in. So they think you're doing something that's making them more successful at their task. So they have positive feelings about you. So now they go back to you. We were told that by a professor in our school to set this up as a business model, because it's perfect. It's a double-edged sword. You're not getting them better. You're not fixing the cause of their pain. So their pain is going to return in the same form or in a different form, because you're not getting at their root cause. So they're going to get hurt again, but they think that you are a good therapist. So they go back to you. So they constantly get hurt. You never fix them. It's just like if you're a car repairman and you never fix the car, but you make the person think you're fixing the car, and they have good feelings about you. And now look, they get to come back to you so many times. Why? So you never fixed the car at all, but they keep getting tricked. It's unbelievable. We were told that verbiage.
Yeah.
Business model. It's disgusting.
All right, let's get back to the ANS. Let's look at the autonomic nervous system a little more. The autonomic nervous system is a network of neural connections throughout the body that automatically takes care of several physiological duties in our body, such as breathing and keeping our heart beating. So it's involuntary mechanisms in our body. So without conscious thought, the ANS is working. Just like all other neural pathways in the body, the ANS is controlled by the brain and the central nervous system. So it's seemingly a part of this mind-body connection. Another role of the ANS is to direct blood flow to specific areas of the body based on nutrient and chemical need at that instance in time. So, for example, when we eat, the mechanism controlled behind the autonomic nervous system, the ANS, will constrict blood vessels around the muscles and dilate those blood vessels that supply the gut and organs of digestion and the GI tract in order to optimize that nutrient uptake and filtration. Since the muscles don't really need much resources, they're not really working. So you need more of that blood and more of those resources to go towards what's working. And in this instance, if you're eating, it's going to be the gut and the GI tract. However, on the other hand, if we're being chased by a bear, the ANS would do the complete opposite, and it's going to direct most of the blood to our muscles that help us run or fight off a bear. This is that fight or flight response. So through this same ability, the ANS is able to direct our attention away from repressed emotions. Blood flow will be shunted away from certain areas of the body by the ANS, which could result in pain via oxygen deprivation, since oxygen is carried through the blood, though the root cause of the pain is not physical at all. So let me just go back again. The ANS, through its ability to shunt blood wherever it wants, could actually be a mind-body connection and a mechanism that will distract you from these emotions from the id, as we talked about, that those aggressive and sexual drives. It'll distract you by shunting blood or constricting blood vessels in certain aspects of the body, cause oxygen deprivation, and now you're not thinking about those unconscious thoughts or emotions aren't going to come out.
Can I just relate this back so people don't think it's so voodoo? The main mechanism behind sleep deprivation and why sleep is so important is believed, and research behind it and scientific mechanisms behind it, that it is the consensus is that the main thing happening is the activation of the sympathetic nervous system and the autonomic nervous system. So when you don't sleep as much, what happens is, picture that you pretend you were alive 20 million years ago when we didn't have society. What are some reasons why you wouldn't sleep? Because you're getting attacked or you haven't eaten, something like that. You're in a state of it's do or die. So the same thing is happening. So it's not voodoo. Sleep, this shows up in pretty much every system, this ANS. It's a pretty common system because, as Angelo was talking about, it has connections to everywhere, from your brain to pretty much every physiological or metabolic component of your entire body?
Your head, your shoulders, your knees, and your toes.
Knees and toes. Continue.
So let's take a look at about how this applies clinically. I want to talk a little bit about Dr. John Sarno. I'll introduce it, and I know Chris will go a lot more into it about his work and what he's done. But he recently passed, but he was an MD out of NYU, taught at the medical college at NYU, and was a professor there. And he did see a lot of patients at the hospital as well. And actually, around 90% of Dr. John Sarno's patients had experienced significant reduction in pain, and many were even pain-free after he taught them about the unconscious mind and the power that it might have. So all these patients came to him with plenty of x-rays and MRIs of what was explained to them as being pictures of disc bulges or pinched nerves and other physical deformities that you commonly hear that are said to be the reason why many people experience this chronic pain. For some reason, no one can treat it. However, the traditional treatment for these diagnoses wasn't working, and most of these patients developed a chronic pain. I'm sure this sounds familiar. So when people came to him for answers, all he did was give them lectures on what he calls tension myositis syndrome, or TMS. He defines TMS as pain resulting from oxygen deprivation from the ANS restricting blood flow to certain areas of the body, so muscles, tendons, ligaments, nerves, even the gut, as a way to distract the conscious mind from the repressed emotions stored in the unconscious mind. Everyone has TMS, however, it lies on a spectrum or a continuum, just like anything else, as Ross was saying, and it will attack everyone with different intensities depending on the chronicity of the pain, the severity of the emotions, and several other factors. Most things in the body are very multifactorial, and it's not different. In his words, when you become consciously aware of these repressed and undesirable emotions, there is no reason for your mind to now protect you from them. In essence, you're blowing the cover on a stealth operation, so there's no need to be stealthy anymore, right? What are some of these?
Blackbird in the area.
Going down. What are some? Let's talk about some of the traditional modalities that are used to treat chronic pain in clinic. As PTs, we're taught about soft tissue massage, transcutaneous electrical stimulation, or TENS, E-stim, shortwave diathermy, which is just a way of stimulating heat, and hot packs are another one, which even though hot packs don't even have the capability to penetrate deep enough to even heat up a tissue, but yeah. So what is the effect that these modalities have on the body? And well, it's an increase in blood flow to that area of application and activation of the gate control theory, as Ross was explaining. So that activation of serotonin going to block the pain signal, blah, 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 all that. So it makes sense why they feel better only temporarily and need to continue to come back as they become dependent on these modalities. And this means more money in our pockets, right, as PTs. So let's talk about some few specifics, some common ailments that people go through before I turn it over to Chris. Many people suffer from unimaginable pain accompanied with muscle spasms. Some muscle cramps may be quickly alleviated by gentle movement, or some people are seemingly paralyzed by the other form of spasm within a muscle. The more severe case may be an attack of TMS. So one way that blood continues to pump through our muscles is via contraction of a muscle. As the muscle pumps, as a muscle contracts, it's pumping blood through our body. It's one way that blood is pushed through. And this activates I just said it pushes blood through. So maybe this muscle spasm is a detection of a significant decrease in blood flow, which will then activate a heavy contraction of the muscle in an attempt to restore the blood flow through its pumping mechanism. It makes sense that this severe muscle contraction could be an automatic response to a lack of blood or oxygen. Let's talk about trigger points for a second. Dr. John Sarno explains from his experience and what he's found in his work and his studies that they're just the most common sites of TMS manifestations, since there really is no explainable structural source of a trigger point. And people say the muscle has a knot. That's, to me, that doesn't make any sense at all. Your muscle can't just unattach from its tendons and tie up into a knot. That just doesn't make sense to me. So, I mean, if anyone finds studies about that, please comment below and post them. These areas, trigger points, are mostly down the axial skeleton and within our postural muscles, so close to the spine and the surrounding musculature. These muscles are from our glutes to our neck and our trapezius muscles, and they are constantly contracting and relaxing in order to maintain the stabilization of our spine and keep our trunk and our head upright. Because they're constantly working, these muscles require the uptake of oxygen for aerobic metabolism. It's that long endurance type of work, right? In other words, these muscles require sufficient blood flow to deliver the oxygen to help with energy utilization and to buffer the acidic byproducts that are produced from burning nutrients for energy. If oxygen isn't getting there enough to buffer these byproducts of its metabolism, then the cells tend to have a change in pH due to the buildup of these acidic byproducts from the cell's metabolism. And this is similar to how we feel a burn during exercise. The byproduct of metabolism exceeds the buffering capabilities of the cell, and we have to now stop exercising due to the perception of pain and that burning feeling. But let me
Just to go a little bit further, why the postural muscles are the way they are, why they get affected, is because, like Angelo was saying, if you're in this situation where you have perceived threat, right? Perceived. So whether it's true, you're getting chased by a bear, or whether it's just perceived as a threat, but it's not truly a threat, like you have a test tomorrow, regardless of what the actual thing externally is, your body's preparing for war. So what does it do? It sends its blood to the prime movers more eventually. So your arms, your legs, the things that are really going to propel you through space are going to get most of the attention, while your postural muscles that have to be maintained throughout the day, every single day, they're not going to get the blood, the oxygen, the nutrients.
they're not made up of the same muscle fiber type, so they're not able to propel you fast enough to get away from that bear, and they don't connect to the same areas that those stronger muscles of the leg do. So yes, in the case of running from a bear, those muscles aren't necessarily the ones working. It's those stronger muscles of the legs, and in that case, that will help you get away.
But that's why even if you have any perceived threat, your body still thinks you're running from a bear, because you're not aware of it. You're not aware of the autonomic nervous system response. So it's going to treat it like you're getting chased by a bear, even if it's just, I got yelled at by my teacher for not handing in my assignment.
Right, a threat is a threat, no matter how.
Threat's a threat, unless you don't perceive it as a threat.
Right.
And this is part of the treatment that we'll talk about, and it's going to be specific to the person and how they're presenting.
Yeah. So now let's turn it over to Chris for a little bit, and he's going to go into a lot more in detail about this. He is the expert within us. Go ahead, Chris.
The field of psychology, in essence, was created to sort of develop a way to understand those complex cognitive and emotional interactions in the brain, that we can identify certain areas of the brain that are metabolically active at certain points, but we can't necessarily quantify all these interactions, which is essentially why the field of psychology was developed. And about a little over a century ago, scientists from, I believe, Germany, Sigmund Freud, began to identify some of these factors. So I just want to go over just a little bit of basic psychological theory through Freud and his three major components of the psyche. One is the id, The other is the ego, and the third one is the superego. I'm going to go over each of these separately, but show how they interact together. So the first one, the id, this is essentially the most primitive function of a higher cognitive being that you can think of. It's narcissistic. It is childlike. It wants its needs met, and it does not want to have to meet the needs of others. Essentially, like the closest you can ever see to the to the true activation of the id is like a baby, an infant. An infant cries because it's upset, it's full of rage, it's angry at the environment and how it has to adapt. But when it suckles on its mother, it's happy, it's satisfied, it's getting its needs met, and it does not have to meet the needs of anything else. That is the id at work, and a child that has not yet developed to the point where it has to meet the needs of society. So Angelo started off his section by talking about evolution, which I think is also a good way to discuss psychology. So the id is essentially how organisms are at their most primal. Then we have the ego. This is what helps organisms to adapt to their environment. It's how, it basically explains the process of natural selection, how some organisms, they couldn't really adapt in their environment. They were too, they didn't have enough, cortical control. Essentially what I believe is that, the organisms who are able to develop more of an ego to combat the id and help adapt to their environment, not just have those sort of, impulsive tendencies, but understand what they had to do to survive beyond just their basic instincts. Those organisms survived, and those organisms had more of a capability to utilize the ego to suppress the id. And these organisms also typically just had larger frontal lobes, more cognitive processing capability, which essentially evolved into us humans. And we have the largest frontal lobes of, any organism that is currently in existence. I believe the most active frontal lobe. So so that's natural selection. That's how the ego balances out the id. Freud says in this specific passage, one might say the ego developed in response to the overarching evolutionary imperative to survive. So that's how we survive. However, nowadays, there's another stimulus. It's the fact that we live in a society. So now we don't have to just adapt to survive and get food and find shelter and live and find water. We have to adapt to interacting with people on a daily basis. We have to have a job. We have to go to work. We have to listen to a boss. We have to drive. We have to talk to people all the time. And this is where Freud came up with the concept of the third part, the superego. This is essentially all the restrictions society imposes on us, the behaviors that we have to adapt to, even though the id really does not want to. And this generates the majority of that internal rage, that conflict. It's the id not wanting to have to do anything, and the superego, essentially, it's more of a moralistic viewpoint. It's showing how one has to function in a society in order to be accepted in that society, and those two are constantly at odds. I personally was mistaken when I first began learning about psychology and suppressed rage, in that I believe that people who were angry are the ones who had the most rage. I believe that suppressed rage corresponded with anger, but that's actually not the case. Suppressed rage, Ross, question?
I'm doing a lot of distraction. I'm just trying to bring this back. You're about to teach me OD shit, but let me just bring this back really quick. So we're physical therapists, right? We're talking about psychology right now. You might be thinking, what the fuck is this? A psych thing? Like, what am I, fucking crazy? This is, as we said, this is related back to the patient's pain. Your pain, your patient's pain, this is directly related to pain. We can't just be looking at positional problems when we talk about musculoskeletal pain or even widespread pain. If somebody's squatting and has knee pain, you can't just look at the position of their knee. We have to look at all the places that pain can be modulated. So keep that in the back of your head. Regarding the cortical thickness, I actually have studies about meditation and different mindfulness and focusing techniques that actually have shown to increase cortical thickness. This is not associated with the increases in amount of actual neurons or cell bodies, but the amount of dendrites that they have, so the ability to make connections. You know what this means. So this literally translates to your ability to be smart and pick up information and focus on something. If you're better at this, your pain will be decreased because you have a better, he'll go into it. But this is really important. So really hear what he's saying right now. Continue.
So essentially, what Freud was saying is that the conflict between the superego and the id is mediated now at this point in our lives in society by the ego, and thus the total output we have is the ego. That's how we exist in society, how we balance the innate needs and wants of our unconscious with the ego and the superego, which exist. I also didn't mention the id is totally in the unconscious. We do not realize it's there. And essentially, wanting to come to consciousness is what Angelo was talking about. That is what we have to keep suppressed via the ego and the superego, which exist in both the conscious and the unconscious. And those help to function to keep those negative thoughts and emotions suppressed and not have them come to fruition, which is essentially why TMS activates in the first place. However, a big discrepancy, probably the major discrepancy between Freud and Dr. Sarno, was that Freud initially believed that there were certain people who have anxiety or depression, they just exist. There are a certain number of people who are just predisposed to it. They're neurotic and experiencing pain in order to sort of prevent these unconscious repressed emotions and desires from coming to the surface, to the consciousness, was a punishment mechanism, which is why people were in chronic pain. It was a punishment mechanism for them being sort of more predisposed to these desires, wanting to come to the surface. However, Dr. Sarno, and I certainly agree with this, came up with a better distinction that instead of being a punishment mechanism, it is a protective mechanism. The body's not punishing you for having these repressed desires because you're different, but instead every single human in the world exists on a continuum of having this repression. You know, some people have more than others. Some people experience it more acutely than others at certain times in their lives. And thus this is not a punishment mechanism, but it's designed to protect us from these thoughts coming to the surface. So that is essentially the mechanism of repression. It's an unconscious process. We don't realize it's going on, but because essentially because the superego is how society imposes its demands on us, every single time you interact with another person, no matter what it is, you are repressing negative thoughts and emotions, because the id does not want to help anybody. If you help an old lady cross the street, if you go to your job, every day you wake up and do whatever you do, you are repressing. It's an unconscious process. You don't realize you're doing it, but you are, and it does lead to an increased pool of rage, which is why you do not necessarily have to say, oh, I'm not an anxious person, or I'm not an angry person. Again, that was a mistake I made. It doesn't matter. Every single human is susceptible to this, and it exists on a continuum from low to high, just like anything. And this one doctor, Dr. Mark Stouffer, I don't know if you guys are familiar, but there was a picture of him carrying a dog down a mountain in Washington who was injured, and it was in the newspaper. He's a pretty cool guy. He's very fit. He's another doctor who practices psychosomatic medicine. And a lot of doctors who work with Dr. Sarno do practice psychosomatic medicine. He posits that there are three different ways, three main sources of this repression from the interaction between the ego, the id, and the superego. One of them is the stresses and strains of daily life. Again, what I just said, you have to go to work, you have to wake up, we have to go to school, you have to study, you have to provide for your family, you have to provide for your loved ones, your wife, your girlfriend, whatever, your kids. All that does take a subconscious toll that we don't even realize is going on. The second one, and this is a bit of a different point, is the residue of anger from infancy and childhood. Now, again, I never took developmental psych. I kind of wish I did. But one principle I'm certainly aware of is that in the developmental years of a child, hence from ages 3 to 8, somewhere in that range, you know, that general ballpark, is when their mind is sort of the most malleable, which is when events can have the largest impression upon them. So children, unfortunately, who were in households with alcoholic parents, abusive parents, God forbid, children who were sexually abused, children who witnessed trauma, children when parents die, that is going to lead to a ridiculous amount of repression just in order for that human to be able to function. In a small percentage of cases, sometimes these kids, they're not able to repress those thoughts. And then they go through their life having severe affective anxiety or depression. They're really not able to function. But the majority of them are able to repress these thoughts. And thus they're able to maintain that balance between the superego, the id, and then thus the ego in the center. And they're able to exist in society. But nonetheless, that does lead to a lot of repressed rage. This is the population of patients, according to Dr. Sarno, I believe, 15 to 20 or even less, 15 to 20% or less of his patients actually have significant trauma that requires deep, psychoanalytic therapy in order to actually get to the root of the problem. But for the majority of people, it's really just the stresses and strains of daily life that lead to repression, which is why a lot of people, when thinking about psych, they go, I wasn't abused as a kid, I must be fine. No, the fact that you exist is going to lead to repression. Existence is a risk factor for anxiety and depression, essentially, and psychological repression, more so. And then the third, this is the most interesting, I believe, is internal conflict. Again, the clash between the id and the superego, but this is not the stresses of daily life. This is more to do with personality. And this, I know it applies to me. I'm not sure about you guys or anyone else out there listening, but a lot of times it tends to come from perfectionist traits and goodish traits. I'm a perfectionist. I always try to be the best I can possibly be. And that, the id does not want to have any responsibility. It doesn't want to be the best it can possibly be. But society, the superego, tells you that you should try to be the best you can possibly be. And that's your personality, the ego in the center, helps determine whether you're a person who kind of doesn't give a shit about a lot of this or a person who does want to be as good as they can. And people who do want to be as good as they can, that's going to lead to a lot more of that conflict between the id and the superego and the ego, and again lead to a lot more repression, which is going to fill that reservoir of repressed rage in your body, and thus at any given point possibly lead to it tipping over and thus requiring a psychosomatic process such as TMS to distract you from those unpleasant thoughts and emotions, in which case you wouldn't be able to function in society if you did have them come to the surface. And again, some people, again, it's a continuum. Some people have a lot less repressed rage than others from the same experiences. Some people have a lot larger reservoirs. They can take a lot more repressed rage without necessarily having to come to the surface. While some people, after a certain point in time, if it's even less, they might have to have this sort of process occur in order to, not experience significant emotional distress, which is why TMS occurs. The pain is a distraction for a severe underlying psychological conflict. And then Dr. Sarno mentions that there are three major ways in which operant conditioning plays into TMS. One of them is if the medical conditions involved are in vogue. This goes back to the book that I believe Angelo ordered that I have, Why Zebras Don't Get Ulcers. Stomach ulcers were a huge problem decades ago. There it is. Excellent. I'm going to start reading that soon. Stomach ulcers were a huge problem in the United States up until a few decades ago, but once medications were, created that could manage those symptoms perfectly, no one got stomach ulcers anymore. Why? Well, because it was a condition, Dr. Sarno would say, it was a condition that was in vogue. It was popular at the time. Oh, I got the ulcer, you got the ulcer. Everyone was talking about it, but once medication came out, the body could no longer use it as a viable defense mechanism because, they knew that there was medication that could treat it like that. So instead, the pain, the symptoms switched. Ulcers were no longer possible because we have something that could treat it quickly. And nowadays, what's in vogue? Well, it's essentially the same axial musculature that's contributing to pain. The low back and the neck mainly, but TMS can act anywhere. But the vast majority of the time, it tends to activate in the low back and then up in the neck and the upper traps. It's why it's because that's all you hear about all the time. Every 5 seconds, every day, I'm seeing commercials for back braces. I'm seeing Brett Favre with his copper fit on his low back, and Jerry Rice. They're playing games. They have their back braces on. I'm seeing commercials for cervical distraction tools that you can use in your house that alleviate pain and fix chronic pain. It's all you hear about. And when you go to the doctor, and they help reinforce this and say, yes, there's a structural thing causing your neck or your back pain, it only helps to reinforce that operant conditioning of something that everybody has. Another example of this, I think, that I've tried to do some research on, but again, can't find anything on it, is the phenomenon of joints getting more achy on shitty days when the weather's shitty out. A lot of the hypothesis behind it is that the low pressure systems help decrease the space in the joint, increase joint compression, and cause pain, but there's absolutely no evidence out there supporting that. However, I guarantee you, and this happened to me like every day in the PT clinic when it's shitty out, every patient in there's going to be like, oh, it's acting up today, the weather's out, I could tell when it's going to rain, and every other patient's like, yep, and they've been hearing that their entire lives, so they're conditioned to expect it to happen. I actually had this one example here of a patient who, this is another doctor who talks about this in this book. There was a patient, this is ridiculous. His doctor told him that he had arthritis in his knee when he was young, and that when he's 50, it's going to cause him pain. And when he turned 50, it caused him pain immediately. Like literally when he turned 50, it was crazy because he was told he was going to happen by a doctor, so he believed it, and it happened. A lot of times when you believe something, it ends up actually happening. Bring this into a bit more of a public health perspective to see exactly how this is impacting the world we live in right now. So I'll just throw a couple statistics at you guys. First of all, I'll start off by saying that as a student who has worked in 2 PT clinics and who has also interned in 2 others, all outpatient, I would say that probably 25% of the patients I've seen are there for low back pain specifically. It's a big problem. According to the CDC, the number of Americans over the age of 65 who report experiencing low back pain recently increased about 4% from 1997 to 2013. The number of physician visits for back pain as a proportion of the U.S. population increased by 5% from 1998 to 2010. And again, these numbers, 4 and 5%, might not seem really big, but they're representative of a country of over 300 million people. So they are indeed significant if you put them in the right context. The study in North Carolina also found, this is more specific, that the prevalence of low back pain over a 14-year period increased from 4% to 10.5% in 2006. And that was independent of both the changes of the age and ethnic composition of the state over that time period. So something was contributing to increased low back pain. They couldn't necessarily identify what. This one study from the Annals of Rheumatic Diseases, based on over 780 cases in over 80 countries, made the pretty bold assertion that currently 1 in 10 people worldwide are afflicted with low back pain, which makes it the leading worldwide cause of disability. And indeed, in the United States alone, each year an estimated 150 million workdays are lost due to low back pain. And this takes a toll on the medical healthcare system of anywhere within the range of $100 to $200 billion. So it is, I believe, financially the greatest burden on the healthcare system in the United States currently. Although that might currently be trumped by COVID, but that's a different situation. And that is all just for low back pain. That's not even encompassing the wide variety of other musculoskeletal problems. Another one I also want to talk about, which you did, is osteoarthritis. Another one of probably the leading sources of chronic pain and disability worldwide. And you did talk about total knee replacement. Specifically, osteoarthritis of the knee joint accounts for over 80% of the entire disease's financial burden over all the body parts it can possibly affect. And knee osteoarthritis currently affects over 20% of U.S. adults over the age of 45. So it does typically tend to affect younger people more so than other chronic pain conditions. And again, as Ross said, there are a ridiculous number of total knee replacements being performed in just the U.S. And again, I'm actually doing a doctoral project on this, which is why I already have these statistics. The number of total knee replacement surgeries was 381,000 in 2002, grew to 543,000 in 2007, and based on the rate that it's increasing, is projected to reach almost 3.5 million by the year 2030, which is absolutely insane for any type of elective surgery. While it's not clear exactly why the rates of the procedure are going up, it is pretty clear through several studies that I'm going to talk about that the prevalence of symptomatic knee OA has increased. This one study looked at long-term trends in knee OA, and they even looked at knee OA in like prehistoric cadavers, and they found that it was indeed present, typically unilaterally. Obviously, they can't measure if it was symptomatic because they can't talk to these cadavers. But over the past couple of centuries in which they can assess symptomatic OA, they've found that since the mid-20th century, the presence of symptomatic OA has approximately doubled, which is very significant. While most people would typically attribute this to two factors. One, the U.S. is getting older. There's a higher proportion of older people, thus more people with OA. Also, the U.S. is getting heavier. The amount of people who are obese is going up, total BMI is going up, and that's another problem in and of itself. However, the study controlled for both of those results, for both of those factors, indicating that some other variable, or perhaps group of variables that we can't identify right now, was involved in the increase in pain. Another study, it was essentially two community-based studies. One of them, over a 20-year period in a specific U.S. community, found a statistically significant increase in most of all ethnic groups in knee OA, again controlling for age and BMI. While the second study in another community, interestingly, found that symptomatic knee pain increased significantly, but radiographic osteoarthritis did not, which means that patients over that time period were having significantly more knee pain, but it was independent of what would formally constitute an osteoarthritis diagnosis. So they were not being diagnosed with more arthritis, they were just having more pain. So again, that's interesting. They couldn't identify exactly what was going on. They had some hypotheses, but none of them were proven within the study. So we've established that it's a prevalent problem for a lot of people. And another problem with it is not just that it's prevalent, but that it doesn't necessarily get better. Patients who have low back pain, 60 to 80% of these patients will experience a recurrence of the issue within 2 years of first reporting the problem, regardless of the treatment they get. It's estimated that over 80% of the U.S. population will experience some sort of a low back pain episode at some point in their lives, and with lifetime recurrent rates as high as 85%. I've even seen studies that say at least 90% will show some recurrence at some point. The numbers are also similar for neck pain, another common cause of chronic pain. The U.S. prevalence of neck pain currently exceeds 30%, and nearly 50% of those individuals will only experience partial relief from treatment, or they will experience frequent recurrence. Shoulder pain also shows a lifetime prevalence as high as 70%, not quite as high as back pain, but that's still insane. 70% of the population will get it at some point. And again, 40 to 50% of these patients report either persistent pain or incomplete relief or recurrence within 12 months of treatment. So not only is it prevalent, but it's also something that tends to stick around and not really get better. So I guess I can go into a bit of these various medical treatments that are available, but again, they're really not that effective. So I believe Ross brought up a couple of these. One of them is the use of opioids, which in recent years, the awareness of the opioid epidemic and addiction has gone up, and doctors have definitely started to prescribe opioids less, but the amount of opioids being prescribed is still increasing, just at a lesser rate. But nonetheless, it's still a problem that has to be focused on. So these statistics I have here show that the prescriptions for opioid back pain increased over 100% from 1997 to 2004, resulting in over 400% inflation-adjusted increase in medical expenditures. So again, a lot of these medical procedures take a huge financial toll on the healthcare system, which is a big deal when you think about it. If they're not being effective, how are we spending so much money on it? The widespread use of opioids, again, it's decreasing, well, it's still increasing, but the rate at which they're being prescribed is not going up as much, but it's still a problem. The Cochrane Collaboration Review for Opioids actually concluded that their benefit does not necessarily justify their financial cost, and a lot of population-based studies show that patients who receive opioids regularly for non-cancer pain, so essentially pain that's not caused by some sort of chronic cancerous condition, they typically have high levels of pain and poor quality of life. And again, have you ever seen someone who's chronically taking opioids for back pain who doesn't have back pain? No, they're still in pain. They're always going to be in pain. They're just also taking opioids. It's not necessarily doing a lot for them. Spinal injections, another one. Again, I've had patients in the clinic, and this is crazy, who would go, oh, I'm getting my injection, so I guess 2 weeks from now, I'll be in pain again. They're already conditioned to believe that the injection is not going to work, and that's probably because they really don't work a whole lot. Statistics I have show that the European and American guidelines both have concluded that the injections do not decrease rates of subsequent surgery, so they don't actually improve one's functional capacity. And numerous randomized controlled trials have shown that corticosteroid injections into spinal facet joints were no more effective than just placebo injections with, saline solution. But despite this limited benefit, Medicare claims showed a 271% increase in injections during a 7-year interval in the late 1900s and the 90s. This which resulted in over a 600% increase in fees for the spinal injections, despite the fact that the Medicare population, the main recipients of these injections, only increased by 12% during that time. So the amount of it was going up, but its effectiveness had not changed or was going down. So spinal surgery, another thing we could talk about. And I do want to preface this by saying that spinal surgery, it's very important for people with debilitating neurological conditions, congenital spinal deformities. It is very important, and I believe the vast majority of surgeons are cognizant in recognizing when it is and is not indicated. But nonetheless, just as in any field of any job you can possibly imagine, including healthcare, there are practitioners that will push for things with financial benefit that don't necessarily need to be pushed for. The National Hospital Discharge Survey found that from 1979 to 1990, the frequency of hospitalizations for cervical spine procedures increased by 45%, while those for lumbar procedures increased by 33%. Now, despite the fact that no evidence emerged in the next decade showing increased efficacy or outcomes for the lumbar fusion procedure, which is a big problem of mine because I don't think it's very effective and the studies don't show it is, the amount of procedures increased by 220%, again, despite no evidence emerging during that time period that they were actually effective.
Can we talk about like the incentives of the doctor? Like what's going on there?
Well, I would just want to say, my point is that I firmly believe that the vast majority of physicians and surgeons out there, they want to do good for their patients. They're not trying to violate any medical.
I agree.
They want to help their patients, and they're doing what they've been taught to the best of their ability in order to help their patients. Do I think that I'm as smart as a neurosurgeon or even a general physician? No, probably not. I'm probably not as intellectually intelligent. But the way that the medical system, think of it as, I think a good analogy is, Henry Ford and the supply line. It used to be, it'd take forever to build a car, right? But then once they invented the supply line in a factory, you could pump out cars like that because it was specialized. Instead of one guy building a car, you had one guy putting on a wheel. That's all he did. That was all he was trained to do. That was his job. That's all he knew. But it made the whole system as a whole far more efficient. And the medical system is experiencing the same thing. And for most things, for illnesses, for certain medical conditions, you break a bone, you have a fracture. The medical system, being as streamlined and as bureaucratized as it is efficient, and it's also financially efficient. But in the specific case of something where we have to take more time to delve into it, in the essence, the mind-body connection, which is what's behind the epidemic of nonspecific chronic pain, that method of doing things, which is what's been developed for everything, is actually not the most effective route. But we essentially are not conditioned to treat that way. It's just not the way it's been developed. If you started saying, oh, you could probably build a better car, but you have to build one every day instead of 1,000, they'd say, no, fuck off. We're not going to make any money off of this. And we don't care about the outcomes. And that's essentially what's happening in the medical system. They want to do the best, but they're doing the best with what they have, and what they have just isn't good enough for this specific problem.
And this specific problem and these numbers you brought out is so prevalent. And especially now, and it's kind of like a loop of the problem is affecting the healthcare system, and the healthcare system kind of made the problem type of deal. The healthcare system keeps rooting the problem over and over again and keeps reassuring these false narratives over and over again. And then you're causing this problem, and then it's not working in the healthcare system because it just doesn't work, right? For these types of things. All right. What else do we have to say, Chris? What else we got?
Well, I suppose all I wanted to do is give a brief overview of the operant conditioning and psychology and how it plays in. I think I've done that. I did just want to mention one more thing, which Angelo also mentioned when he was talking, is that a lot of the reason that the field of psychology and thus approaching medicine in a mind-body way doesn't get a lot of respect is that it can't be approached using the scientific method. Everything in science is, determined by randomized control trials. Are they double-blinded? Do we have the proper sample size? And we have to get positive results in order to justify the use of interventions in the future. However, with an approach like TMS, which is why a lot of physicians will say, oh, it must be bullshit because, you can't use a randomized control trial. Well, how can you? Are you going to have one group say you guys have TMS, and you're going to have a control group saying you guys don't? How are you going to determine the individual psyche and the beliefs patterns of each of these patients when that's all that's going to determine the outcome, not what control group they're put into? If half of the patients that told to have TMS don't buy into it, you're not going to get any accurate results. So it's essentially you can't really quantify it using randomized control trials, which is why it's something that's probably never going to get the respect it deserves while medicine is, in the way it is, the way the healthcare system is the way it is.
And also the health, the RCTs, randomized controlled trials that come out, they're looking at one variable. And I was talking about this with Ange the other day. Like they only have one variable most of the time that they're looking at. Pain. All right, we did an exercise intervention. What was the effect? They're not looking at these. This is a human system, right? We got somebody. What's the human? Not. You're not a diagnosis. Just as you were saying, like everyone's on a spectrum for everything. We all have conversion disorder at some level. We should do a whole pod on that too. We all have TMS on some level. We all have this at some level, right? We all have pain on some level. This is not a diagnosis. You can't diagnose somebody with something, right? So we can't just be looking at one system. We have to look at the whole human. What are they eating? This is how flawed this could be. If I look at people with pain and then I put them through an exercise intervention, an experimental group and a control group, and see which one did better, but so many people don't have a certain micronutrient, and I don't have to be specific, but that doesn't allow them to do X, Y, Z, right? That's just one other system. You have to start talking about these systems too. How do we quantify? How do we measure? How do we keep track? And I think it's very difficult for these studies, but I think that's what's going to start coming out more in these studies is they're going to have to, because people are starting to realize that this is a whole system working together. It's not neuro, it's not physiology, it's not musculoskeletal, it's everything's working together at one time. So there's no way you can separate them in studies. There's just too many variables you're not controlling for, right? So that's another good point.
Treat the patient, not the body part. In essence, that's really the solution. It just takes a lot more time for each individual patient, which is not conducive to the way healthcare is organized right now.
Why PT is in a bad state right now.
Yeah, when you're seeing 30 patients a day, how much time do you have to spend with each individual patient? How much time do you have to spend talking to each patient? In my last rotation, I got 5 minutes, straight major muscle test, then you're done. Next patient. I'm like, what do you want me to do? I can't get anything done in 5 minutes. It's ludicrous, but that's the way it's set up. That's the way it's been set up because it's what's been financially feasible.
And what do you think that, I think a possible solution is that there's not enough resources. There's not enough people that understand what we're talking about, the human connection between systems. There's not enough people that understand that. So you can't, yes, can I just myself treat a total of 200 people in my life, but charge them an absurd amount? But what about the people that don't have a lot of money, right? So I'd be targeting financially, they'd be having a lot more money because they're spending more time compared to a regular physical therapist, right? So they're spending a lot more money. What about the people that don't have money? So now you have to get into more people just need to be in the healthcare system, right? We can't have, in my opinion, you can't have a therapist treating 10,000 patients a year. It's just, you can't build you can't build that many relationships. You need more, not therapists, you need more people that know what the fuck they're talking about, and more people with more relationships, more connections. That's the only way to solve the problem, right? More people have to know what the fuck is going on, whether that's the patient or a third party that's teaching them like we are, right? I think that's a good way to go at the problem.
In the end, now we're at the point where if the medical field really wants to grow and truly do what's best for the patients, and just for society in general, it just needs to begin to acknowledge the idea that the mind has an equally important role in controlling the human being, more so, not more so, but just as well as those equally, important organs of the body, the organ systems of the body that we're so fond, that we learn about all the time in class. And I just think that the more, like you just said, the more that we bridge that gap, that's the only thing we can do right now. But we're trying to understand, how the body works as a body, not just as a system of the body.
Just because you go through, it's 4 years of medical school and then 4 years of residency and you become a surgeon or a doctor, doesn't also mean that you're not doing the same thing and that you're just regurgitating what you, sort of from like a Good Will Hunting, regurgitating out of your textbook. It's not a lack of intelligence or a lack of knowledge. It's just a lack of trying to recognize a wider perspective and not trying to be so myopic and narrow to your field. Back in the days of Freud, medical practitioners, they studied everything. They got a patient, they had no idea what was going on, and they made a holistic assessment. And is it something that we can realistically go back to? No, I don't think so. But I also don't think that it's a complex problem, but I think it's a really simple solution, just like the analogy with the plague. All we have to do is understand what to do. We don't have to apply any advanced technology. We literally just have to understand and educate. That's it. And it's applied to our treatment, I think.
All right. That's the end of this podcast. I want to thank everybody that stuck through, and we really hope that everybody learned a lot. There's a lot of information here. You can go back. You could slow it down. You could speed it up if you want to hear Chris speak even faster than he does.
We sound better when we're sped up, honestly.
Yeah, we do. Speed us up. You comment below, interact, ask questions, share with somebody, like it. Maybe even follow us on Instagram if you're feeling really good. If
you're feeling
if you're feeling really parasympathetic. So yeah, at AR Doctors, just comment on our stuff. We like to have conversation, and we actually like helping people understand what's actually going on rather than false narratives like we talked about today. And these false narratives exist throughout health and throughout human mechanisms. It's not just pain. These false narratives exist in nutrition. They exist in movement. They exist in other mental processes. They exist in sleep. So we're trying to debunk these things and really get a more holistic understanding, and not a dogmatic view of a physical therapist or a dogmatic view as a pediatrician or a neurosurgeon. We're trying to get a holistic view, and it's definitely a hard route, but yeah, we're doing it. All right.
Adios, muchachos.
Very good.